How many joints are in the body? It depends, of course, on how they are counted. Should we count 1 for the elbow joint or 2, since they are paired? Should we count 3 for each elbow joint, since there are 3 named subdivisions? Most of the 33 sutures in the head are paired, but how should the dentoalveolar joints be counted? Should it be 1 for each tooth or 1 for each root of the several multi-rooted teeth? If you think that's a mess, try to count the intercarpal joints within a wrist. Does popping one's knuckles cause joint enlargement or lead to arthritis? No. But parents have been known to stretch the truth a bit on this issue to keep their children from developing this addicting habit. The actual pop is apparently caused by the vacuum created by the sudden parting of the articular surfaces. This is similar to the noise produced when one pulls a suction cup off a pane of glass. The reason that one cannot re-pop the same joint immediately is related to gasification of synovial fluid that occurs in the vacuum. This gas must be reabsorbed before the phenomenon can be repeated.
Hi, I'm Mike Shively, and this is Introduction to Anatomy and Physiology. Do any of you have any questions from previous session or from your reading, Amber?
Yeah, I was reading the chapter on bone development, and I wasn't really understanding. Would you mind going over that again?
Bone development. I don't really think we got to that last time, Amber. Let's take a moment before we talk about today's subject. Let's go to the overhead camera. Bone development can be divided into 2 forms, or 2 different ways that bones develop. One of them, the simpler one, is called intramembranous ossification. Let's look at this word, intramembranous. Kind of a long word. Ossification. Ossification is just a word that means bone tissue formation. But let's look at the first word for a moment. Intramembranous. We have the intra means within, and then we have this part of the word membranous. Within a membrane is what that says. And we're not really talking about a connective, or we're not talking about an epithelial membrane. This membrane that's being referred to here is a connective tissue proper membrane. What actually happens is that there are some primitive mesenchymal type or stem cell type of cells that develop into osteoblasts. And then the osteoblasts begin forming bone tissue. It's kind of a one-step process. Form osteoblasts, and then the osteoblasts form bone tissue. The other form of bone tissue development is called endochondral ossification. I'll just abbreviate ossification. And this says within, endo, within, and this suffix here refers to cartilage, within cartilage. And this is actually a 4-step process. The first step is a formation of a hyaline cartilage model. In other words, we have a structure that actually looks like the bone, but it's formed out of hyaline cartilage. No bone tissue in it yet. In the second step, and I'm just going to write 4 steps here, 1, 2, 3, 4 under this, and I'm not going to write what they are, but we get a hyaline cartilage model, then we mineralize that hyaline cartilage model. We actually get mineral deposited within that hyaline cartilage model. So what we have then is mineralized cartilage. Now that's not bone tissue, it's cartilage with mineral in it. The third step seems kind of strange because what we do here in this step is actually reabsorb the hyaline cartilage model that has been mineralized. So we form the model, we mineralized it, and then we reabsorb it. But somehow the reabsorption of that mineralized cartilage stimulates the formation of osteoblasts from some primitive cells that actually form bone tissue. So these 3 steps are kind of preemptive, and finally we get down to the step 4 where osteoblasts form, and then they manufacture the components of bone tissue. Now, most bones in our body actually use both of these methods of development. Most of them start out with endochondral ossification, form a hyaline cartilage model first, and then as they continue to develop, there's some intramembranous ossification that occurs particularly underneath the periosteum, allowing the bones to grow in diameter. Matter of fact, we often say that bones grow in length by endochondral ossification because there's a little plate of cartilage at each end of a growing bone where the elongation occurs, and that's endochondral ossification in that location. And then we say that bones grow in diameter by intramembranous ossification. There are a few bones in the body that develop only by intramembranous. Some of the flat bones of the skull are that way. So we don't need to understand the details of it, Amber, but when you read about that in the text, just recall that intramembranous means within a connective tissue membrane, and that endochondral ossification means within a hyaline cartilage model. One of the things that adds some confusing is some nomenclatural variations here. Endochondral ossification within cartilage bone tissue formation is sometimes called intracartilaginous. Let me put those two words on the overhead so we can make sure we see them together. Endochondral, that means within cartilage, that's the four-step process, is the same as intracartilaginous ossification. And the reason this leads to confusion is so easy to confuse intracartilaginous ossification with intramembranous ossification. So these two terms mean the same. Any other questions? Today's subject is joints, arthrology, joint classification and structure. To begin this discussion, we probably ought to define a joint. Who would like to jump into the bandwagon here and give us a definition of a joint? Bryce?
Isn't it where two bones come together and they're connected with some tissues?
Does it have to be bones? That's a question. Can we have other structures besides bones? And you're absolutely right. When bones come together and are joined together by some other kind of tissue, that forms a joint. Amber?
We have joints with our teeth and our gums, so it doesn't have to be just bones.
It can be between the roots of teeth and the mandible or maxilla, so it can be between a tooth and a bone. Adam?
It can be between bone and cartilage also.
We can have joints between bones and cartilages, or in some cases, like within the larynx, we can actually have what? Joints between two different cartilages. So actually a joint is not a particularly easy anatomic structure to define because it can occur bone to bone, bone to cartilage, bone to tooth, or even cartilage to cartilage. Let's look at a graphic that defines this, and it doesn't do it particularly well, but we'll take a look at it anyway. First graphic says the structure formed when two or more skeletal components are united by cartilage or fibrous connective tissue, CT proper. Two or more skeletal components. If we were plug in bones, cartilages, or even teeth into where it says skeletal components, then that definition would be reasonably accurate. So just remember that it doesn't have to be a bone-to-bone junction. And the other thing that we want to remember in that definition is that we're talking about these skeletal structures being joined physically by connective tissue proper or by cartilage. Any questions now? Everybody think they understand what we mean by a joint? Now, what are joints going to do for us? What function do they fulfill? Adam?
They allow movement.
They allow movement. And some of the joints don't allow very much movement at all. Matter of fact, there are a lot of joints where the amount of movement between the skeletal components is quite minimal. And there are other joints, particularly the ones in the limbs, a lot of the joints in the limbs, where the motion between individual skeletal components is relatively free. So we have some that allow a lot of movement and some that don't allow very much movement. Now you'll remember when we classified bones in a previous session in the skeleton, we classified them two different ways. We said all bones either belong to the axial skeleton or the appendicular skeleton, and that was a classification by position. And then we said bones can also be classified by shape into 5 different categories. And we talked about long bones, short bones, flat bones, irregular bones, and sesamoid bones. With joints, we can do the same kind of thing. We can classify joints in different ways. And we can classify them one way by the number of components that are glued together by connective tissue proper or cartilage. And if we do that, we end up with what we call simple joints, if there are only two skeletal components that are coming together, or composite joints, if there are three or more. So that's a classification by number of skeletal components. Simple joints, two skeletal components, and composite joints for three or more. That classification, although it's easy to understand, is not particularly useful in the biomedical field, and a classification based on the kind of connective tissue, specific connective tissue involved, is the one that is perhaps more useful. So we'll classify joints by the kind of connective tissue that's uniting the skeletal components. And this is the most useful taxonomy or classification scheme that's used. And if we do this, we end up with three different categories. First category, if the connective tissue is CT proper, the category is called fibrous joints. And this is also called, I'm just going to write JTS, fibrous joints. These are also called synarthroses. You'll see this term in some texts. If the kind of connective tissue uniting the skeletal components is cartilage, we call them, of course, cartilaginous joints. And if the kind of connective tissue is fibrous connective tissue, but there's a joint cavity containing synovial fluid, we call those synovial joints. So these are kind of like number one, except there's a cavity containing synovial fluid, or some people just call that joint fluid. So these are the three major categories of joints: fibrous joints or synarthroses, cartilaginous joints, and synovial joints. You also see this last category sometimes called diarthrodial joints in some of the older texts, but it's the term synovial joints is the one that's most commonly used today. So we can take all the joints of the body, and then we can divide them into simple or composite, and then each one of those joints can also be classified into one of these three categories by the uniting connective tissue that actually joins the skeletal components together. Let's take a look at some examples of each one of these. We'll go to the overhead camera, and I want to pull up I've got a skull here that we probably looked at the other day, but if we look at it on the overhead camera, I believe it'll show, well, at least, of course, we've got the bones painted different colors here, but I think you can see that the sutures uniting the flat bones of the skull, in this case, come together in a kind of a jigsaw pattern model where the edges of the bones are actually quite undulant where they join together. And because the bones are actually fitting together so tightly, the amount of connective tissue that's required in this kind of a fibrous joint is very minimal. In other words, think of the connective tissue between the edges of the bones as the glue that's going to glue these two different skeletal components together. And so when the bones fit together very tightly, as they do in sutures, a very small amount of connective tissue is required. And of course, these also don't allow very much movement as well. You're all aware that you can't take the bones of your head and scrunch them around in very many different directions, so that the total amount of motion within a suture is quite minimal. Another kind of fibrous joint that's found in between the radius and ulna. Let's go over here to this skeleton and take a look. There's quite a wide gap side to side between the radius and ulna here. You can see this gap. But in life, the two bones are united side to side by some fibrous connective tissue to form a fibrous joint, We can see it on this model, and I'm going to place it up here, and we can look at it on the overhead camera for just a moment. This connective tissue between the radius and ulna is called the antebrachial interosseous membrane. Now, since the bones don't fit together very well because there's quite a wide gap between them, quite a bit of connective tissue proper is found in these kinds of joints. So we have this kind of fibrous joint is, again, another example of fibrous joints called a syndesmosis, and does require quite a bit of connective tissue proper between the bones because the bones themselves do not fit together very tightly. The third kind of fibrous joint, and there are three, again, we'll go to the overhead camera and take a look at this. This is a mandible, and you can see the teeth mounted in the mandible. Between the roots of the teeth and the bony sockets or dental alveoli in which those teeth are embedded is a small amount of connective tissue proper. And these joints are called gomphoses or dentoalveolar joints. And they are yet another example of a fibrous joint. Yeah, Starley?
Are they simple or composite? Like, do you clarify on gomphoses? Because sometimes there's two roots, and do you say that's one skeletal component? Or
That's a good question, Starley. Matter of fact, nobody ever goes there because some teeth have a single root, and some teeth are multi-rooted. And so usually when we're talking about gomphoses or dental alveolar joints, we never go the simple composite route at all. It's a good question, though, and has a theoretical answer, of course, whichever way you'd want to think of it in your mind. So those are just some examples, then, of fibrous joints. Again, fibrous joints, the uniting connective tissue is connective tissue proper, or, as we learned before, that's the same thing as fibrous connective tissue. Any other questions real quick about just examples of fibrous joints? Adam?
Why have sutures at all? If they don't allow movement, why are they there?
You know, that's an interesting question. Certainly, during growth, the skull has to enlarge, and edge to edge, there's a little bit of ossification, intramembranous ossification, that occurs right along the edges or margins of these bones and allows the individual bones of the skull to increase their surface area as the brain enlarges and as our head gets bigger. But once we reach skeletal maturity, I think your point's well taken. We probably don't need any movement. In fact, some of these, in some of the elderly people, will actually undergo what we call synostosis, or bony union. Let me put that word up on the overhead camera for everybody to see. A synostosis is a bony union. And basically what we're talking about here is no longer a joint, it's a union of skeletal components with bone tissue. And so this technically is not a joint. It's a ossified connection where the skeletal components are actually united by bone tissue itself. So back to your point, I think there probably isn't a real need for any movement at all. And certainly sutures and gomphoses don't allow very much movement. You can wiggle, I don't know if you've ever tried this or not, you can take a tooth and you can grab a hold of a given tooth and you can feel just a little tiny bit of movement in it if you push real hard one direction or another. Of course, orthodontists can exploit this, you know, with their wires and bands and so forth. They can actually, an orthodontist can actually move a tooth from one side of the mouth, you know, clear over to the other side of the mouth, given enough time and nothing else in the way. Starley, did you have a question?
oh, on the antebrachial interosseous membrane, does that ever break? Like when you break a bone, does that ever break?
The connective tissue can become damaged or torn when you have fractures of the radius and ulna, but remember, connective tissue proper has a high regenerative capacity, so it reforms and heals quite nicely. All right, second kind of big category of joints was cartilaginous joints. And in this kind of joint, the glue that unites the skeletal components is some kind of cartilage. Now, do you remember the three kinds of cartilage that we talked about in a previous session? Elastic cartilage, hyaline cartilage,
Articular.
and fibrocartilage. elastic cartilage, hyaline cartilage, and fibrocartilage. Of the three kinds of cartilage, only two of them are involved in cartilaginous joints. Only hyaline cartilage and fibrocartilage. And if the skeletal components are united by hyaline cartilage, we call that a hyaline cartilage joint, although I'm sure you realize there's probably a fancier name for it, and we'll take a look at that in a little bit. It's also called a synchondrosis, but we'll look at it on a graphic together in just a moment. If the skeletal components are united by fibrocartilage, we call that a fibrocartilaginous joint or a symphysis. Let's go over here to the skeleton and take a look at some examples of these. The interpubic disc that lies right here between the left and right pubis, uniting the left hip bone to the right hip bone, is made out of fibrocartilage. And the name of the joint is the pubic symphysis. It's a fibrocartilaginous joint because that cartilage, in this case represented by this gray piece of plastic on this model, but in life, that cartilage is fibrocartilage. The intervertebral discs, which join adjacent bodies of vertebrae in the vertebral column, those are made of fibrocartilage, and so those are called intervertebral symphyses. They are fibrocartilaginous joints. So those are a couple examples of fibrocartilage joints. Hyaline cartilage joints, these joints right here between the bony part of a rib and the costal cartilages, those are hyaline cartilage joints. The costal cartilages are made of hyaline cartilage. So the junction here between the bone and the hyaline cartilage is indeed a hyaline cartilage joint or synchondrosis. There's also some synchondroses at the base of the skull between some of the adjacent skull bones that form the bottom part of the cranial cavity. And in growing long bones, remember those plates of cartilage that we mentioned earlier today, those plates of cartilage called epiphysiocartilages or growth plates, those are also formed of hyaline cartilage, and while a bone is growing, those are indeed hyaline cartilage joints or synchondroses. So those are a couple examples then of cartilaginous joints. The third category of joints, and the ones that most people are a little bit more familiar with, is synovial joints. Now, synovial joints, that's a category that forms most of the joints within the limbs, for example. Most of the named joints of the body that a lot of us are already familiar with, like the shoulder joint, like the elbow joint, like the wrist joint down here, like the knee joint, those are all synovial joints. And synovial joints are called synovial joints because they have a cavity containing synovial fluid. Let's go to the overhead and diagram the parts of a typical synovial joint. So what we'll draw here is we'll draw a couple of skeletal components. We'll say, hey, this is one. We'll just say this is a bone. And it's coming together with another bone down here. And we'll label this one another bone. So we have to have at least two skeletal components. Then there's a very thin layer of cartilage on the surface. And the cartilage that's there is hyaline cartilage. So we've got a thin layer of hyaline cartilage. That stuff is actually given a different name. It's called articular cartilage. So it's hyaline cartilage in type, but its name is articular cartilage because it occurs on an articular surface. There is a connective tissue proper capsule out here that actually goes 360 degrees all the way around this joint. And by doing that, it forms a closed cavity. And within that cavity, there's synovial fluid, a small amount of synovial fluid. Well, this capsule actually has two different layers. It's called the joint capsule. And it's got an outer part that's connective tissue proper, CT proper. it has a lining that's formed by a synovial membrane. And that's what actually secretes the synovial fluid. So it's kind of hard to draw two different layers here, but we'll try to do that. Add another line here to kind of represent the two layers. They're actually joined together, intimately sandwiched together. Adam?
Is that synovial membrane an epithelium?
No, it's actually a modified connective tissue with some secretory cells within it. Histologists classify it as one of the connective tissue, modified or specialized connective tissues. Now, that tiny amount of synovial fluid that is found within that joint cavity that's formed by the capsule has two purposes. Not only does it lubricate, as you might suspect, but it also nourishes the articular cartilage. I don't know if you recall or not, but there are a few places in the body where we don't have a blood supply. And I think we might have mentioned those in a previous session, but mature cartilage, there's no blood supply. Membranous epithelium, there's no blood supply. Cornea of the eye and lens of the eye, those are just some examples of places in the body where we don't have any blood vessels or blood. And as a consequence, to keep the cartilaginous cells alive within that cartilage, we have to have some nutritional source coming in from the synovial fluid. So the chondrocytes and chondroblasts within that articular cartilage are nourished by the synovial fluid, which percolates down through them, through the tissue. So that's the general features that any synovial joint has. Now, in addition to those structures, two or more bones, articular cartilage ends, joint capsule with two layers, and then synovial fluid. In addition to those, there are ligaments that are bands of connective tissue that actually stabilize the skeletal components. So all synovial joints have ligaments, and those ligaments can actually be found within the joint capsule, inside of the joint capsule. They can be part of the fibrous part of the joint capsule, or in many cases, they're completely outside and somewhat separated from the joint capsule. And when you read in your reading about intracapsular ligaments, obviously those are found inside the joint capsule. Extracapsular ligaments found outside the joint capsule. And then capsular ligaments if they kind of blend into the joint capsule. The purpose of those ligaments is to increase the stability and help hold the skeletal components in proper apposition. When we get a malalignment, we'll talk about this in a future session, but when we get skeletal components that are not lined up properly at a joint, we call that a luxation or a dislocation. And the purpose of the ligaments is to keep that from happening. The joint capsule helps because it's formed of connective tissue proper, which is relatively strong, but it can be torn fairly easily with traumatic incidents. And the ligaments then are reinforcements that aid the joint capsule in holding the skeletal components in proper alignment. Somebody had a question. Bryce?
You said that the synovial fluid lubricates the joints. So is there a problem with that when people get arthritis? Is that what causes
Yeah,
that?
arthritis, let's look at that word on the overhead. When we will talk about this some more next time, too. But itis is inflammation of, and this prefix refers to joints, so this is inflammation of a joint. There's actually lots of different kinds of arthritis because there's lots of different things that can cause joints to become inflamed. We have infectious arthritis if we have microorganisms that are involved, bacteria in particular, and sometimes some other bacteria-like organisms can be involved. We have rheumatoid arthritis, which has some immunological implications. We have traumatic arthritis, like spraining your ankle, for example, twisting your knee. That's traumatic type arthritis. There's degenerative arthritis, which basically is a breakdown that occurs primarily in the elderly, where the components just basically wear out. So all of those are arthritis. Now, your question was, is there a problem with synovial fluid, production of synovial fluid? Usually, In arthritides, the problem is an overproduction of synovial fluid. Usually when a joint gets inflamed, the first thing that it'll try to do in many cases, about the only way it knows how to react, is produce too much synovial fluid. So maybe some of you have had experiences where you've injured a joint physically, and what's it do? It tends to swell up. It tends to swell up, and that's because there's been some probably chemically induced oversecretion of the synovial fluid. And there's a lot of stretch receptors, of course, in the joint capsule, so when these things swell up, they also hurt big time. Has anyone here ever had to have a joint drained or injected? Anybody had a joint drained or injected? Not a particularly pleasant experience, but sometimes the pain becomes so strong, and the individual has such a difficult time dealing with it because these stretch receptors are overreacting that biomedical personnel will in fact drain some of that synovial fluid off. What usually happens, you get instant relief, but what usually happens in many cases is it'll refill back up again, but a little bit of relief may be worth it for short term. Starley?
Why would you get an injection? When would your body not produce enough?
They typically don't produce, that's what I was trying to answer Bryce, and I probably didn't finish it. There's very few cases where joints go, quote, dry. It does happen once in a while, but it's not a common phenomenon. And when they talk about getting an injection into a joint, Starley, usually the injection that they're talking about is some kind of an anti-inflammatory agent, which they'll sometimes, in some cases, when a joint gets severely inflamed, they'll put some, perhaps corticosteroids, something like that, in there. Not necessarily the best choice, but if you're the star basketball player and you got to play tonight, it may be the only one. Amber?
Have you ever heard of gouty arthritis?
Have.
What happens there?
There are some urate crystals that get deposited. That's another form of arthritis, Amber. Urate crystals will get deposited in the joints and cause some severe problems. I'm not sure what the specific pathoetiology is, but it seems to be an individualistic metabolism, certain metabolites that person produces in excess and causes a problem, whereas the next person would not produce that. Starley?
With the capsule, does it have a lot of elasticity to it? I mean, when you're pushing on it and pushing on it, how come it's not just popping? Does that make sense?
First of all, it's I drew it as though it's kind of blown up there and puffed way out. The reality is the capsule's right next to there's a very tiny amount of synovial fluid in a normal synovial joint, just a scant amount, just enough to lubricate the surfaces. So it's not particularly elastic, though. The fibrous connective tissue, it's kind of like a piece of paper we don't consider very elastic, but a sheet of rubber, thin rubber, would be, right? Well, the joint capsule is more like a piece of paper, stiff paper. It will tear, but it won't stretch just very far before it does. Let's take a look at a graphic which summarizes the classification of joints, some of these things that we've been talking about. We said, hey, we can classify them by the number of skeletal components into two categories, simple joints and composite joints, and we can classify them by the uniting connective tissue into these three categories. And we looked at some examples of fibrous joints. Remember, we looked at sutures, we looked at gomphoses, and what was the third one? Remember the third one? Syndesmoses, yeah. Okay, cartilaginous joints, if the uniting glue between the skeletal components is cartilage, we call it a cartilaginous joint, and we said there's two basic categories of those that when the skeletal components are united by hyaline cartilage and when they're united by fibrocartilage. And finally, synovial joints are the ones where there is a synovial fluid containing cavity between the various components. All right, I want to take a look at the subdivisions. I want to look at one more graphic that will show us the subdivisions of these three joint categories. So if we'll go to that next graphic, this is basically a summary of what we just said, but let's just look at it again. The fibrous joints are also called synarthroses, and again we said syndesmoses, sutures, and gomphoses. Dentoalveolar joint is probably a more user-friendly name there because I think you immediately jump to what we're talking about. Gomphosis is not a particularly familiar word to a lot of people. Cartilaginous joints with the two subdivisions based on whether we're talking about joints where the uniting connective tissue is hyaline cartilage or symphyses where it's fibrocartilage. And then synovial joints, also known as diarthroses. Now, there are 7 different subtypes of synovial joints, but I don't really think it behooves us to try to learn those, because the thing that separates one category from another is just the shapes of the articular surfaces. So there's not a structural difference per se other than, hey, the articular surfaces in this particular synovial joint are kind of ball and socket-like, or they're kind of flat and planar where we get a gliding type motion. I do, however, want to look at a graphic that summarizes these 7 types so that when you see one of these names, you'll realize that's just one of the types of synovial joints. So we'll look at a graphic that summarizes these subtypes, but I don't want you to try to commit these to memory. The 7 types that are recognized anatomically are spheroidal joints, also known as ball and socket joints, ellipsoid joints or condylar joints, bicondylar joints, if we have 2 rounded articular surfaces coming together, a simple hinge type or ginglymus, a trochoid or pivot joint, a sellar joint, also known as saddle joint, and a planar or gliding joint. Again, the thing that all of these have in common is that they are synovial joints. What separates one from another is simply the shapes of the articular surfaces. Any questions there? So I don't want you to commit those or try to commit those to memory. I do want you, of course, to know the 2 kinds of cartilaginous joints and the 3 kinds of fibrous joints, but the 7 types of synovial joints is beyond what we'll try to put in our memory banks for purposes of this course. Any questions on any of that before we go on? Now, this is kind of background. What I want to do next is I really want to take a look at the joints of the superior limb. So what I'm going to do is I'm going to just go over here and start pointing at joints and naming them. So I want you to, when you hear these names and look at these, I want you to realize how the joints are being named. In most cases, it's name the bones involved, and that names the joint. In some cases, we have to name a part of a bone that we may have not learned in this particular class, but nonetheless, the nomenclature is quite logical. This joint right here, between the sternum and the clavicle, is called the sternoclavicular joint. Quite logical. All we did in that case to name this joint was name the 2 bones, the sternum and the clavicle. We added the word joint, sternoclavicular joint. Okay? Out here at the other end of the clavicle, this joint between the clavicle and part of the scapula, and this part of the scapula I don't think you've learned, but it's called the acromion of the scapula. So the name of this joint is the acromioclavicular joint. In this case, we named the joint by naming a part of one bone against the other bone, acromioclavicular joint. So sternoclavicular joint, acromioclavicular joint. Now, I want to keep my finger right here for just a moment, because this is not the shoulder joint, but it's very close to the shoulder joint. Right down here is the shoulder joint between the head of the humerus and the glenoid cavity of the scapula. But when we have injuries to this particular joint, it's often called a shoulder joint injury, or if the ligaments here are torn or damaged, they call it a shoulder separation. So when you hear talk about the quarterback or the baseball pitcher had a shoulder separation, the actual injury in most cases is going to be to the acromioclavicular joint in this location. Moving on down, this is the actual shoulder joint. I've got my fingertip in it between the scapula and the humerus. Shoulder joint, sometimes called humeral joint. If we go on down to the elbow joint, move the camera down just a little bit. Matter of fact, let me go to the overhead camera and we'll just Well, I don't have actually one with a humerus on it, so let's just go right back to this, this one right here. The whole thing is the elbow joint or cubital joint. It can be called either one. And it has three different components. There's actually one between the radius and the humerus, one between the ulna and the humerus, and then there's one side to side between the radius and ulna. All of those are enclosed in the same synovial joint capsule. So the synovial fluid is free to percolate between the articular cartilage in any one of these three components. And they're all three named separately. We'll not worry about the individual names, although they're quite logical, as you might suspect. It's humeroradial joint, humeroulnar joint, and then proximal radioulnar joint. So all of that right in there is the elbow or cubital joint. Now, moving down the limb just a bit, we talked about this one previously. In between the radius and ulna is a fibrous joint. This one's not synovial. There's no synovial fluid. It's a fibrous joint, and it's called the radioulnar syndesmosis. Let's go to the overhead camera one more time, and we'll take a look at the connective tissue proper within there. Again, no synovial cavity, no synovial fluid at all. But the bones are united by this big, heavy band of connective tissue proper. That, again, is the radioulnar syndesmosis. It's the only non-synovial joint in the whole superior limb. All of the rest of these joints that we're talking about are all synovial joints, except for this one right here between the radius and ulna. Then when we get down to the distal end of the radius and ulna, it gets a little bit dicey because we have a lot going on. And I want to go to an overhead camera view of this particular specimen, and we'll take a look at some of the individual entities here. There's a little tiny synovial joint right in this location between the distal end of the radius and the distal end of the ulna, and it's called the distal radioulnar joint. Then all of these articulations involving the various carpal bones, remember I said you didn't have to know the names of the individual carpal bones, but all of the articulations involving those carpal bones can be called the carpal joint or the wrist joint. They have individual designations for different parts, as you well might imagine. This component up here, primarily between the radius and these two carpal bones, is called the radiocarpal joint. These joints in here between individual carpal bones in a side-to-side relationship as well as a proximal to distal type relationship, those are all intercarpal joints. Down here between the carpal bones and the proximal ends of the metacarpal bones, these are called carpo-metacarpal joints. And there's some other designations as well. The intercarpal joints in this location, kind of between proximal carpal bones and distal carpal bones, anatomists will call that joint collectively, all of those at one time, they'll call that the middle carpal joint. There's even a designation, special designation given for this intercarpal joint between the pisiform bone and the triquetral bone. Not a very original designation, but nonetheless quite descriptive, and it's called the joint of the pisiform bone. Interestingly, none of the other intercarpal joints are given specific designations, but that particular one for some reason is. So again, all of these articulations can be called carpal joint or wrist joint, and then individually there's a lot of different names that apply. If we move on down, there's actually some synovial articulation in between the bases of these metacarpal bones, and those joints are called intermetacarpal joints. Down here we have metacarpophalangeal joints, 1, 2, 3, 4, 5, first, second, third, fourth, and fifth, if you will. And then moving on down, these are intercarpal joints. And since we have in most digits two of them, one between the proximal phalanx and middle phalanx, and another one between the middle phalanx and the distal phalanx in that particular digit, we call all these proximal interphalangeal joints of that particular digit, and all of these are called distal interphalangeal joints of that particular digit. Over here in the thumb, there's only one, and that's just called the interphalangeal joint of the thumb because we only have a proximal phalanx and a distal phalanx. Yeah, Bryce?
You said that all the joints in the rest of the arm are synovial, but the carpal joints don't really move at all.
They don't move very much, but they move some. Now, on synovial joints, and this is a good point, on synovial joints, we said that they allow a lot of movement. That's a generality. There are some synovial joints that don't allow very much movement between individual bones. And certainly some of these intercarpal joints, good observation, there's not very much motion between this particular carpal bone and that particular carpal bone. So some synovial joints don't allow very much, but in general, synovial joints allow much more movement in general than cartilaginous joints or fibrous joints. It's kind of like, you know, when we talked about the other day, long bones are longer than short bones, except there are some long bones that are shorter than some of the longer short bones. Did you follow all that? I don't think I can say it again. I probably lied that time. All right. So again, the nomenclature is very logical. Metacarpophalangeal joint, interphalangeal joint, I-N-T-E-R, meaning between, you know, it follows logic. Hazel?
Yeah, I was just wondering, does the first and the second metacarpal joint articulate with each other too?
Let's see if I understand your question. Let's go back to the overhead camera. Now you're asking what?
Yeah, the first and the second metacarpal joint.
Oh,
does it articulate with each
right,
other?
I think what you're asking is right here.
Yeah.
Between the first metacarpal bone and the second,
Yeah.
there is actually no articulation there. In other words, this first metacarpal bone diverges away at such a sharp angle that it makes no actual contact with the base of the second.
So
the intermetacarpal joints are only between the second and third and fourth and fifth metacarpal bones. There's actually not an intermetacarpal joint in this location. Good point. Bryce?
So is there a joint that kind of holds all the fingers together in the palm of your hand, or is that just your skin?
Well, let's take a look at this model. Because again, go to the overhead camera here. This model has ligaments and joint capsules kind of on it. And you can see that there's a pretty tight configuration. Joint capsules and ligaments are all kind of blending together, so you can't really separate them on the model all that well here. But there is, in fact, some shared synovial fluid in these metacarpophalangeal joints. So there's some continuity of the joint capsule space between one joint and the one next to it. Any other questions? Let's do the same kind of thing on the joints of the inferior limb. We're not going to try to necessarily name them all, but we'll take a look at some of them as we go down. I tell you what, I bet you all know the name of this joint right here. What do we call it? Hip joint. Now that's a synovial joint, and you probably know it's a classic ball and socket because we have a very rounded head of the femur bone here, fitting into a cup-like depression called the acetabulum in the hip bone. We've already talked about this joint over here, the pubic symphysis. Now that's a fibrocartilaginous joint. So synovial joint for the hip joint, fibrocartilaginous joint for the pubic symphysis. Moving on down the limb, let me just pull this up a little bit so the camera can catch it. This is the knee joint, or genual joint, it's sometimes called. Patella here in front, femur bone articulating with the tibia down here. The fibula, incidentally, doesn't quite participate. It gets close, but it's really not part of this particular articulation. I have a model of the hip joint. I want to go to the, or a knee joint rather. I want to go to the overhead camera. Well, I thought I had a model of the knee joint. Here he is. Let's go to this overhead camera and take a look. This is from the front. Perhaps I can put it in this orientation, maybe a little more familiar to you. What I want to do is pull off the patella is right here, and this is sometimes called the patellar ligament. Pull that down and out of the way, and you can see two very well-developed extracapsular ligaments here on the side. These are the tibial and fibular extracapsular ligaments. Often in the emergency room, this one's called the medial collateral ligament, and this one's called the lateral collateral ligament of the knee joint. And then if we go ahead and flex this knee joint sharply, you can see a couple of well-developed intracapsular ligaments within it. This one is called the anterior cruciate ligament, and probably someone in here has injured that skiing or skateboarding, or in some cases just stepping off a curb. And this other one is called the posterior cruciate ligament. This one's called anterior because it comes up to the front of the tibia to attach, and this one's called posterior because it goes back to the back of the tibia to attach. Something else that this particular synovial joint demonstrates, this model, are a couple of pieces of fibrocartilage that are present. These are called the medial and lateral menisci. This is the only joint that technically has menisci, and these don't make it a fibrocartilaginous joint just because they're formed of fibrocartilage, but these structures actually kind of fill in the incongruencies between the rounded articular surfaces on the femur bone and the relatively flattened articular surfaces down on the tibia, and they help make the thing fit together better, if you will, which helps with the distribution of synovial fluid. And because these things are tied down, particularly to the tibia, they increase the stability. It would be like taking a bowling ball and placing it on a flat table. It would be relatively unstable until we jam some modeling clay kind of around the base of it. And that's kind of what these do. They kind of help increase the stability. Adam, do you have a question?
Yeah. What's the difference between a meniscus and a disc?
All right, good question. We said this is the only synovial joint that has these structures called menisci. There are a few other synovial joints that also have plates of fibrocartilage in them. The difference between a meniscus and articular disc is simply in a meniscus there's incomplete separation of the articular surfaces, whereas in a disc there's actually a complete fibrocartilaginous plate which separates the articular cartilage of one skeletal component from that of the other. Only a few joints in the body have articular discs. There's one at each end of the clavicle, there's one down in the carpal joint complex, and there's one at the temporomandibular joint in the, quote, jaw region. Very, very quickly, I want to put a model up here. I just want to just briefly go over the rest of the joints here, and so we'll go to the overhead camera. Rest of the joints in the inferior limb. This is called the tibiofibular joint between the tibia and fibula. Up here, it's a synovial joint. And in here, is actually the same thing we had in the superior limb. There's a tibiofibular syndesmosis. And then down here, we get into the tarsal joint complex, just like in the carpal joint complex. Individual names for individual components of it. At the distal end of the tarsal bones, between those and the bases of the metatarsal bones, we have tarso-metatarsal joints. Moving on down, we have metatarsophalangeal joints. And then we have interphalangeal joints parallel in every way to what we had in a superior limb. So those are some of the joints in the inferior limb. In the head, we've already talked about sutures. There's a lot of different sutures, actually about 33 by name, but a lot of those are paired, so there's a left and right version. We've talked about gomphoses between the roots of the teeth and either the mandible or maxilla, the bone in which those teeth are embedded. There are some hyaline cartilage joints down at the base of the skull between the occipital bone in particular and some of the bones that surround it. And then, I don't know how well the camera can pick this up, I'll point it out. The temporomandibular joint is this articulation between the mandible and the temporal bone. So there's a left one of those and a right one of those. And those are the joints of the head. Okay? Sutures, gomphoses, some synchondroses at the base of the skull, and the temporomandibular joint. The joints of the vertebral column include the intervertebral symphyses between bodies of adjacent vertebrae, as well as joints between the adjacent articular processes. I don't know if I can turn this skeleton around, and the camera might be able to pick these up if I turn it around enough here. These are articular processes of adjacent vertebrae. And those particular joints are called zygapophyseal joints. Kind of a strange name, but when you see that in the text when you're reading, you'll understand what that refers to. Then the thoracic cage or rib cage, we actually have a number of joints. There are costochondral joints that we've already talked about. There are sternocostal joints where the costal cartilages come up against the sternum. There are interchondral joints where some of these false ribs, they are costal cartilages, curve up to articulate with each other. And there are a couple of joints here, you know, between the manubrium and body of the sternum and between the body and the xiphoid process of the sternum. So we have a joint across here and a joint across here. Quite often in an elderly person, these will undergo bony union or become synostotic in the manner that we talked about before. Back at the other end of the ribs, where the heads of the ribs come up against the vertebral bodies, there are little synovial joints there, and there's actually a joint between the tubercle of a rib and a little facet on the transverse process of each thoracic vertebra, where those come up together. So those are some of the joints in the axial part of the skeleton. Remember, the hyoid bone is free-floating in soft tissue, so there's no joints associated with the hyoid bone. Now, I know that we kind of blew through those in a real quick manner. You can see the names that we went through in the text, in your text when you read through it. Do any of you have any particular questions on some of those kinds of things? Starley?
I know you said that on the arm you had the antebrachial interosseous membrane. On the tibiofibular joint, does that have a name for it as well, for the membrane in between it?
Let's look at the overhead camera for just a minute, if we can pop to the overhead. It has exactly the same thing, Starley. This particular chunk of connective tissue proper between the tibia and fibula that forms the tibiofibular syndesmosis. It's called the crural, C-R-U-R-A-L, interosseous membrane. Are there any other questions? I see the credits rolling, so I think he's going to tell us we're done.